This recording will go over acute and chronic glomerulonephritis. Glomerulonephritis results from injured and inflammation in the glomerulus, the part of the kidney that filters blood. Inflamed glomeruli allow the passage of protein and blood into the urine. Glomerulonephritis is associated with high blood pressure, progressive kidney damage leading to chronic kidney disease, and edema. Anemia from reduced production of erythropoietin and high cholesterol often co-occur. Glomerulonephritis can cause altered urinary elimination. Many causes of primary glomerulonephritis, or GN, are infectious. Secondary GN can be caused by multi-system disease and can manifest as acute or chronic. Acute glomerulonephritis develops suddenly from an excess immunity response within the kidney tissues. Usually, an infection is noticed before kidney symptoms of acute GN are present. The onset of symptoms is about 10 days from the time of infection. Usually, patients recover quickly and completely from acute GN. In terms of assessment, ask about recent infections, particularly of the skin and upper respiratory tract, and about recent travel or other possible exposures to viruses, bacteria, fungi, or parasites. Recent illness, surgery, or other invasive procedures may suggest infection. Ask about any systemic diseases which alter immunity, such as lupus, which can cause acute GN. Inspect the patient's skin for lesions or recent incisions, including body piercings, because these may be the source of organisms causing GN. Assess the face, eyelids, hands, and other areas for edema, because edema is present in most patients with acute glomerulonephritis. Assess for fluid overload and pulmonary edema that may result from fluid and sodium retention occurring with acute glomerulonephritis. Ask about any difficulty breathing or shortness of breath. Assess for crackles, an S3 heart sound, and neck vein distension. Ask about changes in urine elimination and changes in urine color, volume, clarity, or odor. The patient may describe blood in the urine as smoky, reddish brown, rusty, or cola colored. Ask about dysuria or oliguria. Weigh the patient to assess for fluid retention. Take the patient's blood pressure and compare it with the baseline blood pressure. Mild to moderate hypertension occurs with acute glomerulonephritis as a result of impaired fluid and electrolyte balance with fluid and sodium retention. The patient may have fatigue, lack of energy, anorexia, nausea, and/or vomiting if uremia from severe kidney impairment is present. Circulatory congestion and pulmonary edema often are present, causing acute GN to easily be confused with new onset of acute exacerbation of heart failure. Ask any older adult with symptoms of circulatory overload mimicking heart failure about urine elimination patterns to determine whether the problem may be related to acute glomerulonephritis. Urinalysis shows red blood cells, hematuria, and proteinuria. An early morning specimen of urine is preferred for urinalysis because the urine is concentrated, most acidic, and filled with more intact formed elements at that time. Microscopic examination often shows red blood cell casts as well as casts from other substances. A 24-hour urine collection for total protein assay is obtained. The protein excretion rate for patients with acute GN may be increased from 500 mg per 24 hours to 3 grams per 24 hours. Serum albumin levels are decreased because this protein is lost in the urine and fluid retention causes dilution. Serum creatinine and BUN levels may be elevated, indicating impairment of elimination, while GFR may be decreased to 50 mL per minute. A kidney biopsy provides a precise diagnosis of the condition, assists in determining the prognosis, and helps outline treatment. Interventions focus on managing infection, preventing complications, and providing appropriate patient education. Managing infection as a cause of acute GN begins with appropriate antibiotic therapy. Stress personal hygiene and basic infection control principles such as hand washing to prevent the spread of the organism. Teach patients the importance of completing the entire course of the prescribed antibiotic. Modifying immunity with drugs can also benefit patients with acute glomerulonephritis that is not due to acute infection, but is related to excessive inflammation. Corticosteroids and cytotoxic drugs to suppress immunity responses may be used. Preventing complications is an important nursing intervention, especially when fluid and electrolyte balance is disrupted. For patients with fluid overload, hypertension, and edema, diuretics and sodium and water restrictions are prescribed. The usual fluid allowance is equal to 12 to 24-hour urine output plus 500 to 600 mLs. Patients with oliguria usually have increased serum levels of potassium and BUN. Potassium and protein intake may be restricted to prevent hyperkalemia and uremia as a result of elevated BUN. Nausea and vomiting or anorexia indicates that uremia is present. Dialysis is necessary if uremic symptoms or fluid volume excess cannot be controlled with nutrition therapy and fluid management. Plasmapheresis, which is removal and filtering of the plasma to eliminate antibodies, also may be used. Preparing for self-management includes teaching the patient and family members about the purpose of prescribed drugs, the dosage and schedule, and potential adverse effects. Ensure that they understand diet and fluid restrictions. Advise the patient to measure weight and blood pressure daily at the same time each day. Instruct him or her to notify the primary healthcare provider of any sudden increase in weight or blood pressure. If short-term dialysis is required to control fluid and electrolyte balance or uremic symptoms, explain vascular access care and dialysis schedules and routines. Chronic glomerulonephritis develops over years to decades. Mild proteinuria and hematuria, hypertension, fatigue, and occasional edema are the only symptoms. Although the exact cause is not known, changes in kidney tissue results from infection, hypertension, inflammation from immunity excess, or poor kidney blood flow. Kidney tissue atrophies and functional nephrons are greatly reduced. Biopsies in the late stages of atrophy may show glomerular changes, cell loss, protein and collagen deposits, and fibrosis of the kidney tissue. The loss of nephrons reduces glomerular filtration. Hypertension and renal arterial sclerosis are often present. The glomerular damage allows proteins to enter the urine. Chronic glomerulonephritis always leads to end-stage kidney disease. In terms of assessment, ask about other health problems, including systemic diseases, kidney or urologic disorders, infectious diseases such as streptococcal infections, and recent exposures to infections. Ask about the overall health status and whether increasing fatigue or lethargy have occurred. Identify the patient's urine elimination pattern. Ask about whether the frequency of voiding has increased or the quantity of urine has decreased. Ask about changes in urine color, odor, or clarity, and whether dysuria or incontinence has occurred. Nocturia is a common symptom. Assess the patient's general comfort and ask whether new onset dyspnea has occurred because fluid overload can occur with decreased urine output. Ask about and observe for changes in cognition, such as irritability, an inability to read, or an incapacity during job-related functions, or disturbed concentration. Changes in memory and the ability to concentrate occur as waste products collect in the blood. Assess for signs and symptoms of circulatory overload. Assess for uremic symptoms, such as slurred speech, ataxia, tremors, or asterixis, which is a flapping tremor of the fingers or the inability to maintain a fixed posture with the arms extended and wrists hyperextended. Inspect skin for yellowish color, texture changes, bruises, rash, or eruptions. Ask about itching and document areas of dryness or any excoriation from scratching. In terms of diagnostic assessment, urine output decreases. Urinalysis shows protein. The specific gravity is fixed at a constant level of dilution around 1.010 despite variable fluid intake. Red blood cells and CAS may be in the urine. GFR is low. Serum creatinine level is elevated. BUN is elevated. Decreased kidney function disturbs fluid and electrolyte balance. Sodium retention is common, but dilution of the plasma from excess fluid can result in a falsely normal serum sodium level or a low sodium level. When oliguria develops, potassium is not excreted and hyperkalemia occurs. Hyperphosphatemia develops when serum levels are greater than 4.7. Serum calcium levels are usually low normal or slightly below normal. Disturbances of acid-base balance result in acidosis. The kidneys are abnormally small on X-ray or CT in chronic glomerulonephritis. Interventions focus on slowing the progression of the disease and preventing complications. Management is systemic and consists of diet changes, fluid intake sufficient to prevent reduced blood flow to the kidneys, and drug therapy to control the problems from uremia. Eventually, elimination is so impaired that the patient requires dialysis or transplantation to prevent death.